Hello, I'm Donal McCauley and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today I'm talking to an old friend, that's Lyle LJ Fagnan, who's based in Oregon. But Oregon's not the whole story, because LJ, you've really had a very exciting start to your career, something that none of the rest of us have experienced. Tell us a little bit about it.
So I started my medical school career over 50 years ago. We had a 51st class reunion, and I was reflecting on how I got started in medicine. I went to school here in Oregon. I was at a time when family medicine was just getting off the ground. I think it was 1969 that the specialty was recognized, and I graduated in 1971. And so when I came out of medical school, hanging over my head was the military draft, and I wasn't excited about the possibility of ending up in the Army. I was married and had a 1-year-old son, and so I had met a pediatrician from the Anchorage, Alaska Native Hospital who thought that might be a good option. And the United States Public Health Service was considered part of the uniformed forces. So I did a rotating internship in Hartford, Connecticut, and then went from Hartford straight to Alaska and ended up in a place called Bethel, which has about 4,000 people and is on the Yukon-Kuskokwim Delta. And I was very young. I went to medical school after 3 years of college and hadn't had much in the way of life experiences. But I was pretty interested in different ways of doing things. And so in Bethel, it was a center of 48 Eskimo villages. I was a general medical officer. I became the community health director, but my first week there, I ended up doing 3 appendectomies under spinal anesthesia. But the major thing that Bethel did was the native people, the Yupik Eskimos, taught me how to be a doctor. They taught me how to care for a community. And as I mentioned, it was the center of 48 villages. And there were 8 of us general medical officers, and we divided up the villages. One of us had radio traffic for a week, and we would visit with the health aides and hear who they were seeing. And then, like, I had 6 villages, and I made 1 to 2 trips a year out to each village by plane mostly, and sometimes by river because the river was frozen solid, and you can drive in the winter to some of the villages. And as I mentioned, the Eskimo people were really kind and accepting of people like myself, even though they knew that we were transient, that we would only be there for a couple of years. In my case, I was there for 3 years, but I really got to understand how communities operate, and it influenced the rest of my career. That immersion into the native culture and appreciation of it takes a village to raise a child, and I came away having lived that mantra. I didn't want to go right into practice. I knew there were family medicine residencies, and I would visit with a leader of family medicine in the early days, Ted Phillips, who was a family doctor in Sitka and later went on to be the department chair at the University of Washington, and was then the dean of the School of Medicine at the University of Washington after having been a country doctor. And I'd visit with Ted every year, and he said, LJ, there aren't any residencies for you. They weren't any openings. And so I did get to apply to one they were just starting in Boise, Idaho. But I used that time there to think about what kind of practice I wanted to have, because I had a lot of clinical experience from my time with the Indian Health Service. As I mentioned, I wanted to do a residency, and I kind of knew a lot of the clinical things. And even in Boise, they let me continue to do things like C-sections and some of the things I did in Alaska. But the major thing I got to do was think about what practice was like. And when I was finishing up medical school, I became acquainted with a physician called Larry Weed, who was the father of the problem-oriented medical record and wrote a book in 1968 on medical records that teach and provide comprehensive care. And I was fascinated by him. And indeed, I had the opportunity to invite him to come to the medical school I was at to give a talk. He had an article in the New England Journal of Medicine in 1968 that talked in detail about his vision of the problem-oriented medical record and the use of the computer. He was early in the phases of computerized medical records. And I also became acquainted with one of his proteges, Harold Cross, who had a practice in Hampton Highlands, Maine, and wrote a book called The Problem-Oriented Medical Practice. And so while I was doing my residency, I contacted Dr. Cross, and he invited me out to spend a month with him to see what this practice was like. And he had one of those models that I wanted to adopt. He did a comprehensive evaluation of every patient he had. He had a document called The Principles of Practice that guided he and his partner, Jean Bajorn. And so I thought about that during my residency after that month. And I was rifling through my program director's desk, and I came across the Robert Wood Johnson Foundation application for a project called the Rural Practice Project. And they had a goal of subsidizing 30 practices in the United States. This was rural. They came at the premise that it was hard to be in rural practice. People weren't succeeding, and we needed to change the model. So they came up with a set of criteria, and they would provide a 4-year stipend of about $500,000. Back in 1977, when that was a lot of money. So they had a goal of 30 practices. The criteria were that you had to be nonprofit. You had to have an administrator. You had to have a team practice. And so I became one. I don't know if you can see the book, but I became one of 13 practices that the RWJ funded. They could only find 13 practices that met the criteria that they wanted to fund. And so I went into this community on the Oregon coast, community of about 4,000 people. I said I wanted to set up practice. Again, I'm just out of residency. And so I met with the people. I created a community board, and I became an employee of the community. And so this practice in 1977 had myself, a wonderful administrator I was fortunate to work with, who was really great, a physician assistant, Susan, that I hired from Seattle, a health educator, a nutritionist, 2 part-time psychologists, a dentist, a medical assistant, and a receptionist. And so we started out with what people view now as these model practices. And this was back in 1977 that we were able to start this practice. And so we stretched the funding out for 5 years. And during the early days of the RWJ Rural Practice Project, we would meet as a group. It was administered out of the University of North Carolina School of Medicine. Don Madison had it. And we would meet each year, the 13 practices, and talk and share what we were doing. And it was a lot of camaraderie. And when the funding went away, I got lonely. And so I was contacted by Larry Green, who was directing the Ambulatory Sentinel Practice Network of North America that had Canadian and US practices. And my practice became practice number 29 with Aspen. doing practice-based research. So early on, I had this exposure to people that were pretty thoughtful about the discipline of family medicine and trying to create the evidence for what we did and do. And that was foundational for what I did later.
That model of practice that you introduced way back, that was very far ahead of its time. I mean, Larry's network of research practices, that again was really innovative. But then you ran with it yourself, and the Oregon Practice Network grew from your ideas.
Exactly. And so I was able to get a position at Oregon Health and Science University. And my first job was to set up the first primary care center for the university in the community of Portland. And we took half the residents with us. And so I did that for the first 9 years I was there. And then in 2002, established the Oregon Rural Practice-Based Research Network, and was able to get some funding from the Agency for Healthcare Research and Quality. Not much money, but enough to get started. And so it allowed me to stay focused on my rural roots. We really did grow this network into something that had a lot of meaning for practices that wanted to be connected to something bigger, is rural. And they felt like they couldn't identify with others very well. And so I had one physician, we were having a roundtable, and John had tears in his eyes as he said, "This is the first time I've been connected with other folks that are thinking like I am and want to do something different and create a better way of doing things." And that was quite gratifying to be able to work with these rural practices. And every time I went out to visit one, I came back inspired. And so I was able to actually share with these practices some of what I did during my early career, the principles of practice that we set up, the community orientation, those principles of practice that we had things that talked about how we had a responsibility to teach, we had a responsibility to do research, and we had a responsibility to the community.
Those three principles are absolutely fundamental. They're tremendous to think of embodying that in the network. But it's not just the network of education and community. You did some very interesting research. I know you did some work on heart health.
One of the advantages of a practice-based research network and also having connections with organizations like the Agency for Healthcare Research and Quality, you get to see what opportunities are out there. And we had the what was called Evidence Now, the largest quality improvement study I think that's ever been done around heart health. And so I was able to partner with a physician, Michael Parchman, who was in Seattle at the time, and we had Healthy Hearts Northwest, which was one of the groups that participated in Evidence Now. And a lot of papers have come out of that, led by some very thoughtful people.
You've always been ahead of the game. I mean, really, you've always been that step ahead of the rest of the posse coming along. One of the other things that fascinated me that you were way ahead of the game was with decision support and shared decision making.
I see people out there that I admire and look at their work and think, I want to know them better. You interviewed France Lagarde a bit ago. And so I got to know France through my interest in shared decision making. I was able to be one of the demonstration sites for the shared decision making group out of Harvard that Michael Berry led. So I think we had maybe 6 or 7 demonstration sites. There was Stanford, the Massachusetts General, Dartmouth, and others. And we were a little rural community on the Oregon coast. So we became the rural component of that demonstration project to show that you could introduce shared decision-making aids into practices, and they would get used, and that patients and the clinicians and staff that use them would value them.
Now, there's another aspect of some of your writing that must have been considered very radical by your colleagues and peers. And that is when you introduced the idea of having a pharma-free practice.
So back in 1977, when I started this practice in Oregon with the Robert Wood Johnson Foundation, one of the principles of practice was how to deal with pharmaceutical reps. This was early, and it said we would schedule them once a month, and they could drop off their samples, and the samples were only to be used for people that didn't have money, needed the medication, and we would dictate what samples we wanted. And so this was those early days. And then when I set up the practice at Oregon Health and Science University, one of the first things I did was said, we will not have pharmaceutical reps coming in on their own. What we did is we were fortunate to have a PhD pharmacists there. So we set up a once a month talk where we would invite the pharm reps to come in, and they would come in as a group, and they would share what they were going to present, but they had their other pharmaceutical reps around the table. So it only lasted about 3 months before they decided they didn't like that format. But we didn't take any samples. Indeed, one of the practices in a small Central Oregon community, David Evans, he wanted to go pharma-free in his practice, and he published 2 papers about that we worked with him on, was how he went about that and measured the effects of that decision on prescribing practices. And this was one of the early efforts to realize that there's no free lunch when you're dealing with pharmaceutical reps.
So looking back at all these enormous steps forward that you made, where do you think family medicine is going now? What are the challenges facing the young doctors now?
I'm very concerned about the discipline. Concerned because of the corporate presence in the discipline. And it's very hard to make decisions about what's best for your practice and for your patients, because you have the mothership that's dictating whatever you do has to benefit everybody and the mothership. So there's been a loss of autonomy on the part of family physicians. Medicine's got a lot more complex, and I understand that. And things have got a lot more fragmented. These days, we no longer have the family physician that does everything, taking care of patients in the office, covering the emergency room, taking care of patients in the hospital, taking care of patients in the nursing home. That is a pretty rare model these days, even in rural. The fragmentation of the discipline is of concern. There's a lot less family physicians doing obstetrics. There are a lot less family physicians even taking care of children. We have an aging population, so a lot of us have gravitated towards a geriatric practice. And I wish we would go back to the model of the community-oriented primary care model, where there was less focus on the practice and more focus on our responsibilities of taking care of the community, regardless of who those people are, and regardless of whether they come to our practice, that we are focused on community health. And that's what we measure, not necessarily the quality metrics on individual patients and the people that come into our practice, but on how it looks for the entire community.
That's a wonderful note to end our conversation. LJ, it's been an absolute pleasure talking to you, as it always has been. Thank you very much for sharing your life and your interests and the great steps forward that you made on behalf of family medicine in the US and for all of us. Thank you very much indeed.
You're welcome. Thank you very much for having me.